All right, good evening, everybody, and welcome to our presentation this evening. I am Kim Cox. I'm the manager for oral health here at the Center for Children's Health, led by Cook Children's. And on behalf of the Children's Oral Health Coalition and the Texas Department of State Health Services, we certainly welcome you and thank you for joining us this evening. Ask the Docs is a unique local and statewide effort to bring together dentists, medical providers, and their staff to have tough conversations, about how to make sure that we're taking care of the little ones, the moms, and the whole person. So this is a big part of that, what we're doing tonight. Is through a partnership with the Texas Oral Health Coalition. We are providing dental continuing education credits for this hour. At the end of the presentation, we will have a slide that also has a QR code, and a link will be dropped in the chat box for you to fill out your survey so that you can get your credit for that. So we're very excited about this partnership. All right. So what are we here today to talk about? So today we're here to talk about maternal depression, signs, facts, and resources. This is a very important topic because May is Mental Health Awareness Month. Some of you may think about, well, why would the Children's Oral Health Coalition at a children's hospital be wanting to start a conversation and have a conversation about maternal depression? So as we know, mental health, just like oral health, is part of a child and a mother's overall health. And so they're interconnected. And we know that in order to have a child start out the very best way they can, we have to start with the mom. A healthy mom raises healthier babies. We also know that we at Cook Children's want our children to grow up the very best way possible. And again, we have to start with the parents and with the family and have them as healthy as they can be so that we can have that child get to where they need to be. So I want to introduce myself and let you know my part in this. I am the moderator. My name, like I said, is Kim Cox. A little bit of my background: I am a licensed clinical social worker. Before coming over to the oral health team here at the Center for Children's Health, I worked for 20 years in the psychiatry department at Cook as a therapist. So this is a topic that is near and dear to my heart. Coming over to the oral health team, I wanted to broaden and reach out, work larger in the community. And I also realized that very similar to mental health, oral health was seen as a separate part from the overall health. And we know this is connected to this, is connected to this. And everybody has feelings and everybody has a mouth. So everybody needs to be seen as a whole. In order to address a whole person, we've got to address the mental health and the oral health. You know how it is when you begin thinking about something and a topic, you suddenly get all of these emails or you see articles or things come across that because you happen to be thinking about that. Well, I saw some that I thought were really enlightening in terms of the connection between oral health and mental health. So the recent State of the Oral Health Equity in America survey showed that individuals with severe depression are more than twice as likely to not brush their teeth at least twice a day, which as a therapist makes sense. We know one of the symptoms of depression is poor hygiene. So that makes sense. It also showed that those with poor mental health are more likely to have decayed teeth, periodontal disease, dry mouth. And we also know dental anxiety can certainly play into whether or not somebody seeks out a dentist and care for themselves. But we also know that the opposite is true. So when we have oral health issues in a person, that is affecting their self-esteem, their ability to relate because of smiling, laughing, normal things that we read through a face. Those are all affected. So this is a good topic for us to all be talking about, for us all to be at the table, not only because our patients, we all share patients, but also because we ourselves are people who have mental feelings, we have emotions, we need to be looking out for ourselves, for our colleagues, and for our patients. So thank you again for being here, and we're very excited. All right, I want to introduce our exciting speakers for the evening. So we do have Dr. Kia Carter, and she is a child and adolescent psychiatrist, and she's the co-medical director for psychiatry here at Cook Children's for the consultation services and the inpatient psychiatry. She's been with Cook since 2016 as a psychiatrist, and since 2018, she has led our psychiatric inpatient program serving children in crisis from 3 to 12 years old. Next, we have Lisa Elliott, and she is a licensed neuropsychologist, and she is the clinic manager for Cook Children's Behavioral Health Clinic in Denton. Dr. Elliott specializes in psychological and neuropsychological testing, as well as psychotherapy, and she's frequently requested to be a speaker because she does have such a passion for educating children and their families, young adults, parents on parenting. She likes to talk about all sorts of things. Yes, and is an expert. We also have Helen Thomas, and she is a licensed clinical social worker with 17 years of experience in private practice. And now she is currently the clinical therapist at Cook Children's in our neonatal intensive care unit. So she works directly with many of the moms and dads who could be in crisis or needing stabilization or needing therapy or needing help and support through their time in the NICU and after. So thank you guys so much for being here. And Helen, I think you're going to get us started off with telling us a little bit more about what is depression, what is maternal depression?
So I think this topic is, of course, is on my mind all the time because I work in the NICU and also with caregivers after their infant is discharged from the NICU. And we see a lot of depression in that situation, but also this whole idea of perinatal mental health. Sometimes what a parent or mom is experiencing while they're pregnant leads to that early delivery or leads to difficulty with their pregnancy, not seeking out care or having no prenatal care. And sometimes that's because of fears or it's because of depression. So the number one side effect of being pregnant and having a baby is depression. And that's really, I probably didn't know that before I started my job in the NICU 6 years ago. So it's super common, and it happens to a lot of moms, and a lot of times they're not treated. So 1 out of 7 women suffer from postpartum depression. And so that's 20% of every mom that has a baby. And so I really and we're focusing on postpartum depression, but I really like to think about perinatal care. So while a mom is pregnant and after they have their baby, all that time is really important for their health and also for the health of that new infant. So some of the signs of depression, and we may talk a little bit more about this, and please feel free to ask questions. So like frequent mood swings, crying, sadness, ups and downs. I sometimes with younger parents, irritability, or just with anyone, that mom irritability is a big sign of depression. Outburst, I think withdrawal, and sometimes what we see in the NICU, and you may have experienced, is a mom who doesn't seem like she's bonding with her baby, and that doesn't mean that she's not going to be a great mom, but she may be depressed or she may be suffering from some other anxiety or mood disorder. So Postpartum Support International is an awesome organization that really supports both moms and dads with perinatal mood and anxiety disorders. And so even though we're focusing on depression today, I want everyone to be able to think that there are all kinds of anxiety disorders that might come with pregnancy and with being a young mom. And so depression is one, anxiety, and really in the NICU, I see much more of that acute anxiety occurring, probably more than depression. Even though we screen for depression, I think probably there's more anxiety. So panic disorder, obsessive compulsive disorder, postpartum PTSD, bipolar disorders, and postpartum psychosis. And so the PTSD part is interesting, right? Because many times something has happened with the pregnancy, during the pregnancy, that has been traumatic to that mom, or many times there's a super traumatic birth. And a long time ago, before I had my first baby, like 32 years ago, a friend of mine who was going to medical school, and he was doing his internship in Waco, at Hillcrest in Waco, and he looked at me and he said, anything can happen during delivery to the mom or the baby. And I was like, oh, that's not good, but it's true, right? That anything can happen. And so some births are very traumatic. Having a baby at home, having a baby on the way to the hospital, or in the ambulance, those things really do happen.
Helen, I just had more of a comment than a question, but that first sentence that you said, the number one side effect of pregnancy is depression. That really hit home to me. How would somebody know that it was depression versus maybe just hormones? Or this is just hard.
Yeah,
I'm a new mom.
I think it is difficult. I do think it's a huge adjustment for, particularly for first moms, maybe, and maybe some of our adolescent moms that are pregnant, that's a huge transition. So sometimes it might be hard to figure it out. Is this just adjusting to being pregnant and getting ready to have a baby and making this huge transition, or is it depression? So I would say things like, particularly after birth, if it lasts more than 2 weeks after birth, if a mom is still really struggling with hygiene, or attending to the baby, or feeding, crying often, not being able to really associate with other people, those sorts of things, I think would be what you would be looking for, especially any thoughts of self-harm or for harm of the baby, or it would be super scary. And so the depression piece is important. And I guess I just have a bee in my bonnet about postpartum psychosis, because it's really rare, but it does happen. And it happens with moms who have never had any mental illness in the past. And so just if you experience someone who doesn't seem to be in reality, either pregnant or after their infant is born, that's always an emergency, and help is needed right away with that situation. And again, I think knowing that letting moms know that there is treatment for depression, and being able to go to see a therapist, or the possibility of medication is always there. Does that answer the question, you think, Kim? I don't know if I talk too much. I mean, Dr. Carter or Dr. Elliott can add on to that if they want to, but how would you know if a mom was clinically depressed rather than the baby blues? Would you guys, do you have anything to add to that?
Hey, it's Dr. Carter. I would add, just like you said, Helen, the length of time. So if it's just for a couple of days and mom's not feeling well, or just not up to the norm, that's one thing. But when we see it consistently, and you mentioned the key number, 2 weeks, that's about the time of an episode of depression that we classify as a major depressive episode. And so I would say definitely, if a mom is struggling for longer than just a couple of days, that's when you really want to start to kind of look at some of those concerns and talk with your doctor, or talk with other friends or things like that, to kind of say, hey, I haven't been feeling myself the last couple of weeks now. I'm really worried, to kind of get out there and maybe get the support. So I think that's the biggest thing, because it is hard after having a baby, and everything changes, right? And so your mood, hormones, but looking at that length of time that you're experiencing those symptoms is pretty important.
Yes, and I think the other thing that I would add to that for patients or friends in your life or family, just really trying to normalize that experience. That, again, that's the most common side effect of pregnancy and delivery, and there's help. And so you don't, I really believe the quicker a mom can get help, the more important, because all that beginning time is super important for that baby. So mom being able to bond, hold, rock, feed, all those things is really important to the first few weeks of life and after that. And so I think just really trying to normalize that for a mom and give them some resources where they can get help. And I really do. Again, I'll go back to this PSI, that Postpartum Support International. They have groups online. They have a list of therapists that are trained in PMADS, trained in treating moms with PMADS, and also I think just gives good information for a mom or a dad. Like, these are the things to be worried about. And I've been impressed in the NICU with fathers voicing their concern about their wife. And I think a dad knows when a mom's not okay, and them really stepping up and going, okay, we need to do something and get some help for this mama.
Well, and I think that's so what you guys both pointed out about the 2 weeks, because as a provider, if you know you're seeing a mom that with a 1-month-old, okay, that would be a time where if you're seeing these symptoms continued, hey, that might tell us something. If you have a mom in the chair that is very tearful, that is has poor hygiene, you're seeing changes like that. If you know how old is your baby? If they're 3 months old and that's still going on, then there's a real reason for concern versus I'm just struggling to adjust a little bit to a brand new baby.
Right. I think too, Kim, I think the other thing I would, as a provider, look for is this person, I've seen them before and they were talkative and engaging and, being able to engage socially. And if they arrive and they're like, their facial reflect is completely flat, and if when they start talking, they start crying, things like those are kind of pretty big red flags that something's changed. And I think no matter where you are in the medical field, that patient, we want to think about the whole person and how their mental health is affecting themselves, and if they've had a baby, to really think about that and what are the things that we might be able to say or do in those situations. Just going to explain this slide. It's many people have probably seen this before, but it's called the still phase kind of experience. And so you'll hear it explained, but the mom comes in and she's interacting with her 1-year-old in the way that they always interact. So, this little 12-month-old is not using words, but she or he is interacting with where they're looking, where they're pointing, their back and forth conversation. All of us that have children or around kids know that little people still have conversations, even if they're not using words, right? they're still talking to us. And so she's interacting with him, and then she is instructed to turn around and not face the baby, and then turn back around and not show any facial expression and not respond to her baby. And the amount of time that it takes for that baby to decompensate and really kind of start falling apart is really shocking. So let's watch this video real quick on the next slide.
Babies this young are extremely responsive to the emotions and the reactivity and the social interaction that they get from the world around them. This is something that we started studying 30, 40 years ago, when people didn't think that infants could engage in social interaction. In the still face experiment, what the mother did was she sits down and she's playing with her baby, who's about a year of age.
I'm like a girl. Oh.
And she gives a greeting to the baby gives a greeting back to her.
Yeah.
This baby starts pointing at different places in the world, and the mother's trying to engage her and play with her. They're working to coordinate their emotions and their intentions, what they want to do in the world. And that's really what the baby is used to. And then we ask the mother to not respond to the baby. The baby very quickly picks up on this. And then she uses all of her abilities to try and get the mother back. She smiles at the mother. She points because she's used to the mother looking where she points. The baby puts both hands up in front of her and says, "What's happening here?" She makes that screechy sound at the mother, like, "Come on, why aren't we doing this?" Even in this 2 minutes, when they don't get the normal reaction, they react with negative emotions, they turn away, they feel the stress of it. They actually may lose control of their posture because of the stress that they're experiencing.
Okay. I'm here. And what are you doing? Oh, yes. Oh, what a big girl.
It's a little like the good, the bad, and the ugly. The good is that normal stuff that goes on, that we all do with our kids. The bad is when something bad happens, but the infant can overcome it. After all, when you stop the still face, the mother and the baby start to play again. The ugly is when you don't give the child any chance to get back to the good. There's no reparation, and they're stuck in that really ugly situation.
Okay. Any questions about that video? It's pretty stunning to me to see that baby really kind of fall to pieces that quickly. And when I was talking about flat facial effect, that's exactly what she was. There was no way that baby could tell what was going on with their mom, and they were used to interacting back and forth and doing that serve and return, like you do something, I do something, or maybe we do the same thing together. I look where you look, and all of those little things throughout the first year of life are super important. I was telling Kim, I, for whatever reason, did this deep dive into eye gaze, especially for babies, even little infants and even premature infants, and that eye contact from mom in particular, like there's a dyad, and that lets that baby know that they're seen. It actually lets them know they're real, and it helps develop their skill of empathy for the future. And so just that doing that back and forth with a baby is super important. And what I think about when I look at that video is, what about a mom who's depressed and that's how she looks all the time? And so that gets to a place where a baby may give up trying or isn't getting what they need. And so our portion of why this is important is we want that mom to get back healthy as quickly as possible.
Thank you, Helen. Yes, that, every time I see that, it, it pulls at your heartstrings a little bit to see that baby in so much distress so quickly, knowing that mama, is not giving that feedback, which has so much to do with sort of the attachment. And I think, Lisa, Elliott, were you going to talk to us a little bit kind of about that attachment and how that really does affect that first year of life?
Yes, happy to. In fact, that video is a great demonstration of, a child's desire as well as the effort that they will go to try to seek that attachment interaction. All children need healthy stimulation for healthy development. And we've actually learned that there's these sensitive periods, or we call them also windows of opportunity for the development of certain capabilities. So if in humans, we as humans, if certain synapses and neural pathways are not repeatedly activated, those abilities may diminish, or actually they can be discarded. And infants, as you saw in this video, have a genetic predisposition to form strong attachments to their primary caregivers, but they are not able to achieve those strong attachments or those trusting bonds if they're either severely neglected or if they receive little consistent quality, one-on-one interaction. And Helen had mentioned earlier about this, time frame. Well, what we know is the sensitive period for healthy attachment really does occur prior to 24 months. So this slide here looks at both healthy attachment, what we call secure attachment, and the other one is called disturbed attachment. And we'll kind of go through those little circles a bit. So when an infant is in need, whether it's hunger, fatigue, they're hurting or whatever, they're going to cry out their discomfort. And that's their way of communicating their needs. So as a parent soothes them and meets their needs, that infant then becomes satisfied, relaxed, calm, and regulated. And the cycle of trust develops, and that process is repeated. So that is a big part of the bonding process that occurs. And then as the infant is rocked and held and the mother coos and talks to him, just like you saw in the video, and smiles, then the infant begins to mimic those smiles and those facial expressions. That too then contributes to this healthy bonding process. So it's this kind of very, finely tuned, relationship that is occurring. And that cycle specifically aids in healthy brain stimulation. So secure attachment provides the baby with the best foundation for life. It creates this eagerness to learn, kind of a healthy self-awareness and trust and relational skills. So that's the secure one. Now the one that's disturbed attachment. So when a baby, experiences discomfort and the mother does not respond, or her responses are inconsistent, that cycle is what we call disturbed. So in this situation, a child or a baby is unable to regulate, and they have this heightened sense of anxiety and fear. And as their needs are not being met, and maybe that neglect continues, what happens is what Helen mentioned earlier, they actually cease crying, and they'll actually go into a survival mode, all of which is going to interfere with healthy brain development. And if the mother is inconsistent with her care, then what happens is that the infant continues to remain anxious, concerned, more fearful, really wondering whether or not their needs are going to be met. So a disturbed or an insecure attachment is one that fails to meet the baby's needs of safety and trust. And so what that can lead to is confusion of identities, difficulty with learning, and even particularly difficulty relating to others later in life. So what this slide shows, it provides, which is really nice, what I call developmental specific information regarding the consequences of a disturbed or insecure attachment. So, you can look at all this and, read it yourself, but largely what it means is secure attachments foster autonomy. They're having much more willingness to explore and learn. They have increased playfulness. With that in mind, they're going to have better cognitive performance. They have increased successful interaction with peers, and they're going to have more enjoyment with being with peers. There's going to be increased ability to rebound from disappointment or else loss. There's a willingness to seek support as well as give support. There's less aggression, less withdrawal. There's a decrease in depression or less depression and anxiety. And at the same time, you have more increased self-awareness and emotional well-being and more balance in life. There's more confidence, and there's just improved relationships in general.
Good sense to me when you learn about attachment and how it affects the baby, why this subject of the maternal depression is so important to a children's oral health coalition. That this is important because it affects that, but also obviously the mother is important as well. But sure, you see that attachment and how it affects a child throughout their entire life, even when you're just looking at the first couple weeks and years of life. So, that makes some sense.
I think what's interesting is people don't understand that those first 3 years of life are absolutely critical. And 90% of your brain is developed within those first 3 years. Mm-hmm. And for that attachment piece, and we say mother, of course, this is what we're talking about is maternal depression, but, a child needs to have a healthy caretaking or caregiver relationship.
Mm-hmm. And that goes to also speak towards the importance of dad's mental health as well, that it's not just mom or grandmas or aunts or anybody that's really hopefully alongside the mom taking care of that child, but also maybe taking care of that child in lieu of the mom. Mm-hmm. So is there a way to, if we realize that if the attachment, is there a way to teach attachment?
That's a really good question. We don't actually specifically teach that because some of it's that natural thing that occurs. But yes, you can. I believe you can teach attachment. And I think that educating a parent or mother and a father on how do we do that, like about the eye contact, how do you respond, the tones in which you respond, the amount of physical contact they have. I mean, I'm sure Helen talks about this, sees this up in the NICU. Oftentimes you see them holding that child skin to skin contact, right? And you guys encourage that.
Skin to skin is really crazy because I guess we shouldn't know it, but just the science behind that is really interesting because when a parent, a caregiver holds an infant skin to skin, oxytocin is produced in both the mom and I'm going to go with mom right now, mom and baby. So it's almost like this love circle starts happening. And so there's a lot of bonding that's built into the way that we're made. And so to me, that's super cool. There's a lot of times with a mama that like what happens sometimes in the NICU is the baby's born and comes to our NICU before mom can get there. And there's no way hardly that most moms can calm down until they hold their baby, because then it's visceral, like the whole, the parasympathetic system calms down. And it's like they say, I totally feel so much better because that that bonding has started to occur. And my baby's really here and I'm really here. And we have this oxytocin kind of love bond going on while we're holding.
It's interesting you say about the oxytocin. It's actually called the love chemical.
Yeah.
Or the cuddle chemical. So it's there's actually research and science to support that. So having that skin to skin contact, teach them how to do that, teaching the tones, teaching them how to respond. Also, I think too, teaching a parent and a mom, like what is going to be typical crying? What should you expect? So they don't respond to it in an unhealthy way. But yes, I do think we can teach, and I think we can model.
Absolutely. I was just going to add on to that. I think there are a lot of unfortunate messages that parents, young moms get about spoiling an infant, or that baby doesn't like you, or like just misinformation. You can't really spoil a baby by holding them too much. That doesn't happen. So those sorts of things. And, I don't think that infants, will like or dislike someone. So, and I agree with teaching those kind of engagement skills that are similar to that eye contact, playfulness. Being playful is important, having that back and forth conversation. And I was going to add one more little thing because I have too much to say. There's a really good book called 30 Million Words, and it's about the first 3 years of life. And what this, research says is that words really do matter. So the amount of words, the quality of words, the taking turns, using more words, a parent can actually, you can tell them you're creating neurons in your baby's brain and you're up to this 3 years of life, which is the most significant. So you have the power to impact not only their IQ, but their emotional IQ and their ability to regulate, which of course is a gift for the rest of their life.
Well, and I think that, it's, addressing just what we've learned, what you guys have all talked about, we're addressing the moms and where she is. I mean, that I can imagine that depression, that anxiety, the PTSD, the psychosis, all of that would be interrupting this. And so we need to recognize and get that mom the help she needs as quickly as we can to try and make sure that this attachment and bonding starts as quickly as possible.
You know what, Kim, there was a study that was done that was similar, that the video that we watched, there was a study that was done that actually taught moms how to engage with their children, so they could see how to do it. And I can't remember, I've been sitting here thinking about what the name of that study was, but it's very powerful. And I do know other people still use it today. It's out there.
I love that one. And I love coming at it from a place of grace, new moms are new moms, and none of us knew what we were doing. And, this is hard. And they will cry and they will not always respond and just to you doing, because maybe that's not what they're needing at the time, but it's hard. And so I love coming from that, because I think that's the first step to then being able to have a conversation about, are you struggling with this? Do you think that this is more than just kind of getting adjusted to this? And so how do we get you the help that you need?
I was going to add to Kim, the other thing that happens sometimes with moms in particular is that their family doesn't believe in medication, and they don't believe that our family doesn't believe in getting help. I mean, that's literally what they said, that we're not supposed to ask for help. So really doing that normalization and education about like this, you're not out of the norm. This is happens often with moms with new babies. And I was also thinking about the feeding part, that when that's difficult, that can be really hard on a mom, because we have that mammalian part of our brain says we should be able to do this and it should be going well, even though our prefrontal cortex may say, well, that doesn't make sense. I just don't think, it's really hard to calm down that mid part of your brain. And so again, like education and giving moms all kinds of options for feeding their baby in those the first weeks and months of life.
Hey, Kim, this is Tanya. I want to go ahead and just bring up a chat, since this is kind of in the conversation of what Dr. Elliott and Helen are talking about. But a question was asked, are there any comments on how to reach new immigrated refugees that are already isolated due to language and cultural norms, especially those new moms?
That's a big question. I think I don't know about with the language barrier. I think that's really hard, difficult, but I think just recognizing that however they came here was already traumatic, right? And so that the mom and dad or whoever was with the mom, that their journey was traumatic. And so I think addressing that for the parent is really important. I don't know exactly how you would do that, but we know like a journey, it makes my heart break, because that people are at our border and they would not have made this trip if there was a better option for them. And so just recognizing that they've already been through a super difficult time.
Well, and I would imagine that that's where a medical provider might be a touch point for them, because that may be somebody who is seeking, care somewhere here once they get here, whether that's for an illness or for, just to kind of get, a well check. But that might be a place where, you can kind of reach them when they come in. You have them in your office, you're already talking to them, and that's a place where you could possibly start that conversation.
Yeah. As a dentist, I know I asked the question, but for the viewers on tonight who do not know me, I'm Dr. Tanya Fuqua, and I am the Director for Child Oral Health here at Cook Children's under the Center for Children's Health. And I'm blessed to work with all these ladies that are here tonight to speak with us. But I'm going to hope that any of the dentists or dental professionals on here know this, and we can help each other as colleagues to know a smile is a universal language. So I hope that any of us with our smile, no matter what that smile looks like that baby noticed mama didn't smile. I mean, I was getting sad watching mama still faced. So I hope that we all know in healthcare that a smile is worth more than a million words, if we can do that to comfort that family, no matter what language that is. And hopefully mom will feel comforted and feel comfortable enough to maybe share by pointing or showing or kind of making motions. So I just had to add that in there as a dentist.
Yeah, I'm going to add this, it may or may not make an impact, but I recently had a doctor's appointment with a new physician. It actually was a orthopedic for hand, because I've had some arthritis. So I went to this doctor, and I thought he did everything right. So he did, sat down and looked at me eye to eye. He used appropriate touch, so touching my arm, which of course that oxytocin we're talking about, that calms people down. In the course of our conversation, he was playful. He made a joke about what I was saying I thought was the cause of this arthritis. And so he did all the things that were right. And I think just remembering that as a provider at any point with medical care, even in a short amount of time, you can help a person feel comfortable enough to share what's really going on with them. And I think for an immigrant, we know whatever has already happened. If they're here, then their road has not been an easy road. And particularly if mom was pregnant during that, transition of getting here to the States, then that baby probably has been impacted, and kind of reassuring that parent that things, may have been hard to this point, but we can recover, right? We can have some resilience and recover, even when things have been really, really hard. So.
Well, and Helen, you bring up a good point. I was hoping that Dr. Carter might be able to speak to, but these are tough conversations for people who aren't in the mental health world to have. If we've talked a little bit about the signs. So if a provider is concerned, how do they kind of ask that question? You're the expert on asking the questions.
We have the resources at the top, but below those are two very common questionnaires that we use. I know at Cook Children's, our pediatricians are using the PHQ-9, which is basically one of the very common questionnaires that they can easily screen for depression. They're doing it at every appointment that a child comes to. And this is relevant for kids and adults. These questions are asked very similar for both generations. So if you look at some of the questions, it's, have you felt down, depressed, or helpless? Have you felt tired, having little energy? And then the patient is able to say 0, 1, 2, 3. And then there's a scale that basically says, we don't have it on here, Kim, but it may be important for us to send out, but it's a scale that kind of says 0 to 5 is no concerns. 5 to 9 is mild depression. 10 to 14, I think, is moderate. And so what you do with that is a little different. So if someone has more mild depression, you kind of just check on them, make sure they have support systems, maybe refer them to a counselor, but just kind of make sure you watch them the next time they come to the office, because it could have been a hard day. It could have been a hard couple of weeks. Just like we said, that time frame was really important when we see clients and patients for assessing those severity of symptoms. But when we get into like 10 or more, we start to get a little more concerned. And that's usually when we want to make sure we refer someone to see a counselor, most definitely. And sometimes medication is needed. I know medication can be scary in pregnancy, and I know some people really worry about that. And what we encourage people is that to first start counseling. First, talk to someone. First, let someone get to see the severity of the symptoms that you're experiencing. Is this affecting your day-to-day life? Is this affecting anything that you're not able to care for your child? And then, like Helen mentioned earlier, if we get into just not being able to get out of bed, or possibly having some psychotic symptoms, or really bad depressive symptoms where you may not want to live anymore or be around, then usually medication is needed. And most doctors can talk to patients that are carrying or even breastfeeding about some of those safety concerns. I know that the most common medicine prescribed for pregnancy when women choose to be treated and we feel like it's necessary is Zoloft. So that is the medication that you'll commonly be seeing prescribed, and that's called a SSRI, which is basically a medication that's commonly used to treat depression in all ages, to be honest, adolescents, adults, geriatric patients, whoever it may be. It's a very safely studied medication. And out of the SSRIs, that's one that is most commonly recommended and is approved by the ACOG, which is the American Academy of Gynecologists and Obstetrics. So this is kind of a questionnaire and a screener of what we would recommend someone doing in a pediatrician's office or in your dental office. If you start to see concerns, the flat affect, no engagement, poor self-care, this is the place where you start, basically, Kim. And then once you get those answers and you have concerns, then it's referring out for more support, or even to the ER if you're really concerned about someone and they're not safe or you're worried they can't get the help they need today. Most ERs can do emergency assessments for people who have severe depression or even suicidal thinking.
Well, and I think that, that brings up a good point. I know at Cook, because we ask this question of all people, it's, the lead into that is, because we are concerned about a whole child, we ask questions about all different types of their life to make sure that we are treating any concerns. And then we can go into the PHQ when you, so if it's built into what you already do for everybody, then it doesn't seem. And then when it's something, it's, hey, I'm concerned. I just want to ask these questions because I have concerns about, and nothing specific, but just I have concerns about you. I care about you. I've been treating you. I see that there's something maybe a little bit different, and it's always important to me that we're addressing everything that comes in the door. So yeah, those are some.
Normalizing it, like you just said, that totally slipped my mind, but normalizing it. And that's what we've done exactly at Cook Children's. Any child or patient that enters our ER, even though if they're there for leg pain, arm pain, headache, they all have a questionnaire about depression and suicide, just because that is a hard topic sometimes. And so making it part of your normal assessment. It's part of your normal physical exam, as if you were checking your lungs, listening to your heart. Mental health matters, and that's just as important, and it can affect all of those body systems as well. That's a good point, Kim. Thank you.
So you mentioned at the very end about suicide. When would you say, okay, this is a mental health emergency and I need to make sure that I connect the dots and get my patient into, say, an emergency room for an evaluation?
So when we talk about mental health emergency, it's usually kind of these boxes where it's an imminent risk to themselves and imminent risk to someone else, or psychotic to the point where they can't make good decisions. So if someone has thoughts of hurting themselves, thoughts of not wanting to be alive anymore, or even those passive thoughts of wishing I was dead, and it's not something that a provider in a dental office or a pediatrician's office can explore as much, it's worth sending someone to the ER, because usually there's more to unpack under that passive thinking. And then there's thoughts to hurt others. And we're speaking of prenatal moms and new moms. So if there's thoughts to hurt the baby, like Helen said, thoughts of hearing voices or seeing things, those are imminent risks. And that's something that really needs to be evaluated in the ER emergently.
Great, thank you. Yeah, because it's hard to know. I love that this is scored, and we can definitely send out to all the participants what that scoring looks like. But I like that it leads you down, this is a little bit concerning, and just kind of keep your eye on it. This is, where you might refer this score. This is where, and then, yeah, we need to be real concerned and get them into, to help now, certainly. Okay. Well, so I guess we are at our last slide, but I'm sure that there are people in the audience that have some questions or even some comments or things to add to this conversation. Dr. Fuqua has her hand up.
Yes. Well, I literally, Dr. Carter, you brought up something that I think, and I'm just going to be very candid, that I think in my profession in dentistry, I think dentists are definitely more hesitant to maybe report or to ask those questions, or to even recommend someone to go to the ED or that kind of concern. So if I had someone, example, I had someone sitting in my chair and I am concerned about what they're saying and how they're saying it, and I'm seeing signs or symptoms, is that something, like when you say that's an emergency, do you call 911 or do you just tell the patient you should get to the emergency room? I mean, are they going to go there? What's our responsibility as a healthcare provider?
And we work primarily in pediatrics, right? So in pediatrics, it's very different because we're relying on the parent to safely take the child to the ER or to safely get those resources. When it's an adult, if it's something where someone tells you, Dr. Fuqua, I'm going to walk out the door and do something to hurt myself, absolutely, you call 911. So that's an emergent crisis. There's also something called an MCOT line, which is kind of the mobile outreach crisis team, where they will come to that location, or they will come to someone's home and evaluate them emergently in the moment. But if someone says, I just kind of feel like I haven't felt my best, or sometimes I wish I wasn't here, but no, I love my job, I love my family, then no, that's not emergently. And I would say in adult world, if you were to call 911, someone really needs to say that they're going to go out right now and do something where you can't trust that they're going to go make good decisions or get help. And it can't wait, basically. So it's really hard in adults because those things change, and I know it's really hard. And so luckily we're in pediatrics, but in the adult world, if they are actively suicidal or actively saying they're going to go hurt someone else, right? So they're angry at someone, or you don't feel they're safe with their child, their baby, then yes, it is a 911 call. And I know a lot of different counties have police officers trained in mental health, which respond to those calls, which are better at de-escalating and supporting rather than like a criminal offense that you're calling 911 for.
Gotcha. Great. Thank you. I appreciate that.
Yes. And Helen, I know you see that a lot in the NICU, and I've heard you talk a lot about engaging other family members to help in those situations. Can you tell a little bit about that?
Well, I just think if you have that where it's not, this is a mental health emergency right now, we have to call 911, that if you know that it's in your paperwork, there's an emergency contact. And so maybe asking permission of the patient that's sitting in the chair, can I call your emergency person and have them take you to get evaluated? And so it's kind of like a warm handoff is what I like to call that. Like if I can get this person to another adult that can do that, then I know that I've done my part. And unless it's that imminent, like right now we have to call 911 because someone's walking out saying I'm gonna walk into traffic, or I'm gonna jump off the bridge, or I'm gonna go, those sorts of things. And if they, again, like Dr. Carter said too, if they're out of touch with reality, that is an emergency. And so, but I still think, and Dr. Carter, you correct me, if there's someone that we know we can call that's a family member that's dependable and have them come, I think that is okay and an option. What do you think?
No, I think it's a great option. I think just like we do in kids, right? So if we can rely on their parents, then we ask the parent to take the child. But yes, if it's more of an imminent, my concern with psychosis is just that sometimes if someone's not in their right state of mind, they might not even trust that person we're calling. And an adult, you can't force to get in the car. You can't force to walk into the ER. So that's the hard part in adult world, is just that if an adult says, no, I don't need help, then I can't make my sister go in the ER, right? But if I call someone that maybe has a little bit more ability to manage a crisis, they might be better equipped than I am getting my sister in the door, if that makes sense. So I think that's one of those things. And as a provider, I know sometimes we hear that we don't have the time. It's hard to address this in these small time of visits and things like that. And I think that it's hard. It's hard, right, in a clinic setting or office setting when you have 5 other patients already waiting. But you have to think about the best thing for your patient. And bringing in other staff, your nurses, your technicians, your secretary staff. Can someone sit with her until I can call someone to help her, or someone's on the way? So I think utilizing your whole office team and support, because these cases do take time. When someone comes back and says something positive, and you can't let them just walk out the door. And we get that feedback a lot from primary care physicians. And of course, Dennis, I'm sure you guys have patients waiting for you. So it takes a lot of time. And it's just one of those things where we got to get our whole team to help us do that.
I have a question.
I'd like to comment on what you just said, Dr. Carter, that you like to get the whole team involved. I know I find this, that I walk in the room, the patient says something to me, I walk out of the room, and then all of a sudden the patient just throws out all this information on my assistant or my dental hygienist. And all of a sudden they hear all of it and they come back and you're wondering why they didn't tell us. And sometimes I think they feel more comfortable with our staff. They don't see as intimidated. Do y'all feel that same way sometimes? And sometimes it's the opposite. Sometimes they get very angry with the staff, and then we walk in and they're super nice, right? So you can see those mood swings and know that's part of dealing with the patient, right? And that's part of, did they have a bad day? Is something else going on? Were they like this before? I love how y'all are reminding us to remember, if we've seen that patient before, is this a normal behavior that they've had, right? And pregnancy, which is, I know what we're talking about, just adds a whole nother layer to that. So just wondering what y'all's thoughts were on that too.
I think, you know, every patient's different. I think it's probably relatability more. So in what I see normally is that sometimes patients may relate better to me than they may relate to my nurse or my nurse practitioner. You may have different things in common, or it could be something as simple as, oh, I like your hair today. And then now that starts off that topic where I like your hair too. Oh, I'm really struggling with my hair today. So I think it's one of those relatability things where someone's just feeling more comfortable. Of course, the doctor is always kind of the one that patients may be scared of or may not feel as comfortable because they don't want to waste time, or, you know, they don't want to slow you down, or you're too busy. And that's just where you rely on the rest of your staff to support. So I really think it's that comfort level. And from what I see and experience, it's just when someone is more comfortable and relatable to who they may be interacting with.
Yeah, and Dr. Stokely, I see you have your hand up.
Hi, yeah, I do. And hi to everybody who's watching. I'm Rhonda Stokely, and I'm the Public Health Dental Director for the state of Texas. My question is not regarding a crisis sort of situation, but we have a new mom who has come in, and maybe she does have postpartum depression and is trying to work through that. But what I'm seeing, just looking at her, is just neglect of her oral hygiene. I mean, you can, and maybe I'm seeing other signs when she's in the chair as well, you know, personal hygiene overall. Do you have any advice? I mean, this is assuming this person's already kind of trying to work through this, but any advice on how to talk to them and encourage them to, I know it's hard and you may not want to, but to please continue to do those things to take care of themselves, you know, without just saying, because you'll regret it later if you don't. I mean, is there a good way, supportive way to say that?
I was just thinking, one of the questions that and it's not a hard question, but I'd like to ask parents or caregivers is, tell me about your support system. Who is it that you can talk to outside of being, you know, I know you're struggling a little bit. Tell me about your support system. And if they don't have much, then like that Postpartum Support International is a good referral. But just, you get a good sense of what's going on in that person's life. If they're totally isolated, then that's more concerning, right? So, you know, as a dentist, you're not there to solve all of that, but that gives maybe an idea of what's going on in the person's life and giving them some direction on how to get some more support. I don't know.
I think for me, so when because we work in pediatrics, so we're usually talking about the health of the kid, and we really encourage parents to take care of themselves so that they can be the best parent for their child. And that's usually the angle that we use. And I work on the inpatient unit, so I usually see parents in crisis, but they're usually struggling to support the child, which makes them have some lack of self-care, sorry. And so we discuss kind of, you can't be your best self and your best parenting if you don't take care of you first, so you can take care of your child. And I think that's the same thing for your pregnant patients, right? So in order to give your child the best life and be the healthiest, we want you to make sure you take care of your oral health and all your medical needs so that your baby is delivered and has the best ability and best health that they can. So that's just kind of how I spin it when I'm talking to parents, because it is hard. And just when we're struggling with something or we have undiagnosed depression, then they may not know why they don't feel well. They may not understand that this is part of something, not just I'm just a bad person or I'm just a bad mom. It may be something that you really can get help with. And I think that's also breaking that stigma of mental health and addressing that, because a lot of people still struggle with getting help for mental health and thinking, this is just me, I'm just not a good person, or I'm a weak person, rather than this is something treatable, this is something preventable, this is something we can help you with, as long as we know you're struggling with it. So I just try to phrase it that our parents be their best self and take care of them so that they can be the best parent for their child.
Yeah, I'd like to endorse that just a minute with Dr. Carter. I remember when I was pregnant and I went to my dentist every time asked me during the whole time I was pregnant how I was doing mentally and emotionally with my self-care. And he completely validated consistently throughout all of my pregnancies and continued to ask those questions. So I think dentists just engaging normally with the wonderful patient care they all provide anyway with a parent, even as they're pregnant and beforehand, I think that helps as well. It creates that dialogue.
Dr. Elliott, that brings to a great point that someone just asked a question. Should providers be asking male patients with a pregnant wife about postpartum depression for themselves? I see an overwhelmingly yes there that
Yes.
we should be asking if you
Yes.
know that there's a new father or okay. We can't forget the dads. That's right.
It's interesting statistic with NICU patient parents that there really is a thing called NICU PTSD, so postpartum, PTSD after the NICU, and dads are more likely for that to occur later, like 6 months after getting home, having difficulties with PTSD from the NICU. So that's just an interesting statistic. And I do think that everybody's making a huge adjustment, right? If they have a new baby at home. I don't know. I like to laugh about when my first baby came home, and it was like the second week, and my husband looked at me and he said, people think this is going to make them closer. So it's a big adjustment for everybody. And there really can be some depression for dads and a lot of worry about the mom.
Well, I know we're getting close to time, and I know, Kim, you're going to be closing us out here. But I just want to make a quick comment. I really appreciate the speakers tonight. I know as a dentist, I get asked, so why are you doing this? Ask the doc. Why are you trying to bring physicians and dentists together? Well, it's about treating the whole patient. They're a whole person, a whole body, and the mind and the mouth is connected to it. And so I'm really appreciative that you all were willing to be here tonight and talk with us. And I just have to say, for anyone out there listening tonight, that I've been sending out a lot of email reminders, but I want to say that I received a personal email from a dentist that said, thank you, Tanya, for bringing this conversation to the table. Thank you for bringing us together in this way. And by the way, did you know that one of our own colleagues recently committed suicide after postpartum depression? I'm like, Dr. Elliott, get a little tear in my eye. It's hard to hear that. And I think that as healthcare professionals, we also need to take care of ourselves. So I want to remind everybody about that is a healthcare professional listening tonight, that we can't take care of anybody if we can't take care of ourselves. And we need to look out for each other in that. This is hard times. Everything is twice as hard, twice as long, and costs 3 times as much. So we're in a really kind of crisis mode in the world right now. And this topic is so important, and we all have to be at the table together. So thank y'all for being here and talking about this.
Yes, and Dr. Fuquay, I think about that saying, it takes a village. We are all coming into contact with these persons in various ways, and it's going to take all of us trying to think about how they are doing as a whole person, and asking the questions and recognizing the signs and saying, hey, it's okay to go get help. This is not uncommon. And hey, here's some help I heard about. And so, it's a great way to remind ourselves that we're all in this together to try and change our community, certainly. I do want to, of course, thank all of you for joining us this evening. This was something that was near and dear to our hearts, but also we knew was a need. And we had heard that it was a need. And so we wanted to make sure, especially during this Mental Health Awareness Month, to really put this out there and have a good conversation. So thank you for joining us. Thank you so much to our speakers. I appreciate you saying yes when I reach out, because I know that everybody needed to hear all of the wonderful things that you guys had to say. So we would love for you guys to join us for our next one. We do have another webinar called Who Do You Call? Making the Referral Connection, just trying to kind of close that loop in terms of referring between the medical providers and the dental providers. And we do have a great speaker and a great moderator who are going to be joining us then. You can go to the next slide. So this is a QR code you are welcome to use for more information about our Ask the Doc series or to view our past sessions. We do record these because we find that a way that they're utilized the most is because we can push them out to our various partners, who can push them out to the people that they work with, who can so on and so forth. So if you want some more information about the series that we're doing, to get information about future, and then of course view our past ones, you're welcome to do the QR code there. And then the final one, to get your continuing education credits, you can use this QR. You can also, Elaine's going to drop it in the chat box, and we will also send it out so that you can fill out your survey to get your education credits for this webinar. So thank you again to everybody that is here to view, that is here to talk, that it has shared through all of this. And this is not an easy conversation to have, but a much needed conversation. So thank you, and please enjoy your evening.